We're going to be talking about cancer-associated venous thromboembolism and direct oral anticoagulants. Now, I have to admit to you folks that I do have a financial disclosure. My research interest is exactly this topic. And because of that, I've got some funding from the Bristol-Myers Squibb Pfizer Alliance to do a couple of randomized controlled trials, which we'll talk about in a bit. But of course, this is a Pixaban, so be aware of that potential conflict. But I think all of the direct oral anticoagulants are excellent, so I don't perceive an internal bias. So for our 10-minute discussion, 12 minutes here, we're going to talk about the epidemiology of venous thromboembolism really quick, just to talk about just to set the stage for us. And then we're going to talk about DOAC treatment of patients with venous thromboembolism. The DVT prevention is a wonderful topic, but we won't be talking about that today. So just to go quickly through the nature of the problem, first of all, cancer-associated venous thromboembolism is really common, and we have to know about it for that reason. In 2019, nearly 2 million new cancer diagnoses, 14 million cancer survivors, and 20% of each of these individuals will develop a venous thromboembolism. So 20%, 1 in 5. And we also note that 1 in 5 of all the cases of venous thromboembolism in our community is related to cancer. And so this is a big relationship if you simply remember 20% or 1 in 5. And then also, and I like this statistic, 1 in 20 cancer patients will develop an arterial thrombosis. So if you just remember this 20%, 1 in 5, 1 in 20, you'll know the epidemiology quite well. Now we know that cancer-associated venous thromboembolism is definitely cancer site specific. And here we have the big 4 in red related to cancer-specific site scoring. And you can see that they greatly increase the risk of venous thromboembolism, brain, pancreatic, other digestive lymphoma, leukemia. I appreciate that each author will have a slightly different list, but in general, these would be the top 4 or 5. Notice also on this list, the light green at the bottom, prostate, colon, GYN cancers. Yes, these do have a significantly lower risk of venous thromboembolism, but compared to the general population, these risks are also quite elevated. And so cancer site specific, also cancer stage specific. Notice that all of the activity, most of the activity is really occurring in these individuals who have stage 4 disease. And you can see that stage 3, stage 4 greatly increases the risk of venous thromboembolism relative to lower stages. We know that it's cancer duration specific. Most of the activity is occurring within the first 3 months of the cancer diagnosis. And this makes sense to us because we know that what's happening in that time frame is hospitalizations for cancer, surgery related to cancer, placement of a central venous catheter, initiation of chemotherapy. All of these things increase the cancer-associated venous thrombosis risk. And so the vast majority of this signal is occurring early. And then lastly, we know that it's cancer treatment specific. And here are a number of common chemotherapeutic agents for a variety of different cancers. And each one of these alone increases the risk of venous thromboembolism and also arterial thrombotic events relative to relative to other types of medications. So then we lastly note that really cancer-associated venous thromboembolism increases mortality rates. It's the second most common cause of cancer death after cancer progression. And nearly half of these individuals will have a distant metastasis. We know that it increases the risk of death relative to those patients who have cancer but no venous thromboembolism. And definitely it'll increase the risk of death compared to patients with venous thromboembolism but no cancer. So there is clearly a mortality signal here. And here you can see this relationship. And so in the red line is the patients who have cancer with associated venous thromboembolism compared to the blue dotted line where it's the same cancer, so cancer matching, but these patients' curves in the blue line don't have associated venous thromboembolism, so greatly increases the risk of mortality. So just to summarize then the epidemiology, we know that 20% of all venous thromboembolism is attributed to cancer. We know that 20% of all cancers will develop venous thromboembolism. We know that it's cancer site, stage, duration, and treatment specific. We know that the recurrence rates are high, and we know that cancer-associated venous thromboembolism definitely impacts survival, as I showed in the recent slides. So let's hang all of this then. Let's hang all of this on a specific patient. And here we have a 65-year-old male. He has a new diagnosis of pancreatic cancer. He's had an exploratory laparoscopy, which was negative, and so he had a port placed, and he was started on FOLFIRINOX treatment. And we had a conversation regarding starting DVT prophylaxis. He was ambulatory, and he elected not to do that. So within a short time, he develops dyspnea and chest pain. And here you can see his CT imaging in the emergency department. Here on the left is the cross-sectional imaging, and you can see that he has pulmonary emboli in both lobar pulmonary arteries. And then in the coronal views, you can see that he has, again, a fairly reasonable amount of thrombus burden in his pulmonary arteries. And then if you look at the duplex ultrasound of the right lower extremity, you can see here in the compression ultrasound at the femoral artery or some femoral vein, you can see that it doesn't compress, consistent with the diagnosis. And here is the longitudinal views. So the head would be to the left, the feet would be to the right, and you can see that there's a big filling defect here within the femoral vein, consistent with this diagnosis. So the question that we would pose to you as the practitioner, you'll see this patient frequently in your practices, and the question is, so you see this individual either in the hospital or maybe in the outpatient arena, maybe in the emergency department, and the question is, what drug class would you feel comfortable using for this particular patient? Would you use unfractionated heparin, maybe low molecular weight heparin? Would you choose a DOAC, a direct oral anticoagulant, or would you use heparin and bridge that patient to warfarin therapy? I'll just give you a second to think about how you would treat this particular individual if they were presented to you. And so what we're going to talk about now is we're going to talk about old and recent trials of anticoagulation for patients who have cancer-associated venous thromboembolism. We're going back 17 years to the clot trial, and you might ask, why are we going to spend minutes, our precious time, talking about the clot trial, which is now 17 years old? Notice that it was published in 2003. And the reason why is because this trial is the landmark trial against which all future trials are to be compared. And notice that in this trial, it was low molecular weight heparin, specifically dalteparin, compared to dalteparin bridged to warfarin. And there were nearly 700 patients. The primary endpoint of this trial was symptomatic VTE recurrence. Well, the reason to tell you about this particular trial is that, in fact, of all of the randomized trials of low molecular weight heparin relative to warfarin, in fact, this is the only truly positive trial. And therefore, you're going to see that when we talk about the oral anticoagulants in a moment, we're going to be comparing everything to dalteparin because dalteparin was really the only positive trial. Tinzaparin, enoxaparin trials not positive, but dalteparin clearly positive. So here's the recurrent venous thromboembolism in this particular trial. You see that the likelihood of a VT recurrence was significantly lower for those patients treated with dalteparin compared to oral anticoagulant, in this case warfarin. And you can see that that was highly significant, with a number needed to treat of only 12 to prevent a recurrent thrombosis. Now, the vast majority of VT recurrences were in fact deep vein thrombosis. There wasn't a difference in pulmonary embolism, including fatal pulmonary embolism, but the DVT recurrence rate was such that it drove the trial to be a positive trial, and that was all in favor of dalteparin. Now, major bleeding did not differ between the two arms, 6% for dalteparin and 4% for warfarin. Here's the mortality rate, disappointing for sure, but there was no difference in survival comparing these two treatment arms. So based on this data, very important again, almost 20 years old, low molecular weight heparin has been preferred, and preferred not only for the acute treatment, but also for extended treatment beyond the first 3 months of anticoagulation. So potentially putting patients at lifelong exposure to low molecular weight heparin. But we all know that low molecular weight heparin has its limitations. It can be painful, can cause bruising, can be cost prohibitive, and there are a number of other variables which make low molecular weight heparin not as attractive as potentially an oral agent. And so then you might ask, well, what about the DOACs? What do we know about the direct oral anticoagulants? Well, there are now 4 randomized trials which have assessed 3 direct oral anticoagulants, 2 trials for apixaban, 1 trial for rivaroxaban, and 1 trial for edoxaban. These trials are all designed essentially the same, where you have the direct oral anticoagulant compared again to dalteparin. Why dalteparin? Because that's the clot trial, and we have to compare everything to the clot trial. Of course, there was a difference in size for each of these trials, and there was a slight difference in duration of follow-up, the Hokusai trial lasting a bit longer than the other 3 trials. But the primary endpoints were essentially the same, of recurrent venous thromboembolism or major bleeding. Here are the 4 trials that you need to know about. The Hokusai cancer trial was edoxaban, SELECT-D trial was rivaroxaban, and the ATOM-VT trial and the Caravaggio trial were both compared apixaban. Here is the data slide for each of these 4 trials, and you can see that with regards to efficacy, which again is recurrent venous thromboembolism, in general, each of these trials looked advantageous. Now, you might argue that some of them didn't quite meet superiority, but in fact, several of them did, and the data looks quite good. Here is the Caravaggio trial, high p-value, but for non-inferiority. But in general, I think as you look through these data slides, you can see that at least each of the direct oral anticoagulants was not worse than dalteparin, so very attractive across each of the 4 trials for efficacy. What about safety? Well, there was a safety signal favoring dalteparin in the Hokusai VT trial. This was primarily major bleeding from a gastrointestinal source, and we'll talk about that in a moment. You can see that ATOM-VT and the Caravaggio trial, a slightly lower risk of major bleeding for the direct oral anticoagulant. And so what I think we can take home from this combined data is that yes, there may be a slightly increased bleeding signal, but it's primarily related to GI bleeding in patients who have luminal tumors involving the gastrointestinal tract. And so I think that's a really important take-home message. There was no increase in intracranial hemorrhage. There was no increase in fatal bleeding in any of these studies. So it appears that the direct oral anticoagulants are effective. I've just shown you that. And now it appears that they're also quite safe, especially if we exclude patients with a luminal tumor from the gastrointestinal tract. Now here's a disappointing slide, because this shows that apart from the epidemiology data that I showed you, in fact, although we have good treatments now, there was no survival advantage in any of these studies, irrespective of which direct oral anticoagulant was used. And the other thing, which is I think quite important, is because dalteparin was used in each of the trials, you can see that there's a pretty consistent survival advantage, or survival across the trials. Maybe a bit better in the ATOM-VT trial, but nonetheless, the dalteparin being the stable comparator across trials allows us to compare trials to each other a bit. Well, which treatment would patients prefer? Would they rather be on an oral DOAC, or would they rather be on low molecular weight heparin? And this is data from the ATOM-VT trial. And in our trial, we did a monthly survey of patients taking these medications, and the survey was really aimed at satisfaction of the anticoagulant choice. And so here is the data, and we just color coded it to make it easy to look at quickly. So if it was yellow, that meant that it statistically favored apixaban. If it was this grayish color, that meant that it favored dalteparin. And so you can see that the vast majority of these boxes indeed favored apixaban for these monthly surveys. So on the here we have the monthly survey and the questions across the top. At least in this study, we also looked at premature discontinuation rates, and you can see that premature discontinuation rates were quite a bit lower in those patients who were assigned the oral anticoagulant as compared to the parenteral low molecular weight heparin. Well, do the guidelines endorse the use of DOACs for this indication? And the answer is a resounding yes. Now, these guidelines have not been updated since the publication of the apixaban trials, but for the edoxaban and rivaroxaban trials, it was a resounding yes that we can use these for the acute treatment of patients with cancer-associated venous thromboembolism. So in summary then, but is there a pause? Should we hold off at all? And I think we need to understand, was there any patient populations which would give us pause in using these types of medications? And so here are just a couple of bulleted items that I think we should reflect upon. Recall again that patients who have luminal tumors with GI malignancies have an increased rate of GI bleeding, and that was seen both for edoxaban and rivaroxaban. So I would say that if your patient has a GI malignancy, and especially a luminal tumor, we ought to have a pause with using these two anticoagulants for that indication. We don't know much about severe renal impairment. In these trials, creatinine clearance of less than 30 was an exclusion criteria. We don't know much about severe liver impairment. And so in each of these trials, if the liver function tests were more than 3 times the upper limit of normal, they would have been excluded from participating. Severe thrombocytopenia, less than 50 to 100,000. We don't have a lot of data there. We don't have a lot of data regarding patients who have altered GI anatomy. So for example, maybe they've had a large section of their bowel resected as part of their tumor, and hence we don't know for sure if their absorption is adequate for using these medications in the cancer setting. And then lastly, recall that these medications are all metabolized to some degree in the liver, and that the CYP3A4 mechanism, or potentially the P-glycoprotein mechanism, whether it be an inducer or an inhibitor, can alter the area under the curve for these medications, and we don't have a lot of data using these strong inducers or inhibitors concomitantly. All right, so are we done, or do we have one more question? Well, there are some ongoing trials which I think are going to be very useful. The EVE trial is going to help us to understand the proper duration of anticoagulant for patients who have had cancer-associated venous thromboembolism, but have completed 6 to 12 months of anticoagulation. So should we continue with the current dose of apixaban, or should we reduce the dose as in our non-cancer patients? And that's really the hypothesis for both the EVE trial performed in the USA and the APCAT trial performed in Europe. Next, we would ask, well, what about cancer? I mean, if we were going to ask the question of cancer to one of our oncology colleagues, they would say, well, what kind of cancer are you talking about? We tend to lump all of these cancers together, and one might ask, well, is that fair? Because clearly a pancreatic cancer is different from a leukemia, which is different from lung cancer, which is different from prostate cancer. Why are we lumping all these together? And I think going forward, we should aim for cancer-specific data to determine whether we have one treatment that might be better for a specific cancer versus another. We don't know a lot about patients who have brain cancer, primary brain tumors, or metastasis. Here's the number of patients who who were enrolled from each of these trials, you can see that we've only have 85 patients total who had the primary brain tumor or brain metastasis randomized. So we don't have a lot of data from this particular vantage point. And then lastly, there are many patients who have cancer, and they may have an associated splanchnic vein thrombosis, cerebral venous sinus thrombosis, or perhaps a renal vein thrombosis. And for many of the trials, with the exception of the ATOM trial, these atypical thrombus locations were excluded. So we need more data in this particular space. So in conclusion then, we know that cancer-associated venous thromboembolism is common, and it adds both to the morbidity and mortality of those cancer patients who've suffered this thrombotic complication. We know that, and we could have talked about VTE prophylaxis. This is an extremely exciting topic. Based on the amount of time that I was allotted, I elected to eliminate these slides, but we believe that this may be beneficial for our ambulatory high-risk cancer patients. And we know that DOAC treatment appears to be both safe and effective, but we have to consider some of these patient selection criteria when thinking about this type of treatment. And lastly, and I think excitedly, there's a lot of work remaining in this space, and so we can't stop. We have to continue with trials and further assessing some of these really important patient efficacy and safety data. And so with that, I'm going to stop and thank Dr. Tafur for inviting me to participate in this exciting venue.